Hi, my name is Jacqueline Oxenberg. I'm an associate in surgical oncology, as well as director of our national accreditation program for breast cancer at the Geisinger, Wyoming Valley Medical Center. I'd like to welcome you to the Komen Breast Cancer Series, Am I High Risk and What Does That Mean? Today, we have a number of panelists here to discuss high risk for breast cancer. Please, if you have questions, remember to use the chat function so we can answer all your questions. Today we have Mary Wolf, who is a surgical oncology breast advanced practitioner. Mary Wolf specializes in high risk and inherited risk breast diseases. She's involved in numerous research projects and has completed to have her today. My second panelist is Dr. Tatiana Jackson. She's an associate in diagnostic radiology here at Geisinger, Wyoming Valley. She's double board certified in imaging and nuclear medicine. She is also a co-chair of the Inclusion, Diversity, Equity Alliance for the Society of Breast Imaging. She has multiple passions, including diversity and inclusion across the field of medicine. She has also been involved in numerous outreaches regarding mammogram, ultrasound, and breast MRI education. Rachel Schwitter is one of our board certified genetic counselors, and she is a cancer genetics risk assessment clinic provider. She also participates in my co-genomic screening and counseling program. She's a licensed board certified counselor with specialization in cancer genetics. She provides clinical genetic counseling services and cancer risk assessment clinic and my co-genomic screening and counseling program. She's also involved in various research studies that focus on the MyCode participants who carry genetic risk factors as well as family communication. So we're excited to have our whole team of panels here. So I'm going to ask some questions, and we hope to have a good conversation here with our panelists. And my first question is going to be for Mary Wolf. How is breast cancer risk assessed, and how does it mean to be high risk for breast cancer?
Hi, thanks, Dr. Oxenberg. So as many people know, breast cancer, unfortunately, is extremely common. It's actually the most common cancer in women aside from some skin cancers. We say that the average lifetime risk is about 13%. So roughly 1 in 8 women in her lifetime are going to develop a breast cancer, but certainly there are risk factors that increase that risk. So while about 5 to 10% of breast cancers are genetic or there's a hereditary component, the rest are what we call sporadic. But when doing a risk assessment, there's a lot of factors that come into play. And for that reason, it's very important to get a thorough history, which is what I do when a woman comes to me for a breast cancer risk assessment.
Mary, what kind of questions do you ask patients when they come in for your risk assessment?
So I kind of divide it up into sections. First I ask about gynecologic history. So specifically, how old were you when you got your first period? And if they're older in age, how old were you when you went through menopause? The reason we ask this is women who start menstruating at a younger age or who go through menopause at an older age are actually at a bit of a higher risk of getting a breast cancer. And that's because the ovaries, for a longer duration of time, are making those hormones that can stimulate the breast tissue. We also look at reproductive history. So how many pregnancies and the age of first live birth. Women who have children, especially if they're younger than 35, they're actually decreasing their risk when we compare to women who either don't have children or are 35 years or older when they do have their first child. Breastfeeding history comes into play a little bit. So women who breastfeed, particularly for 12 months duration or longer, they're actually reducing their risk of developing a breast cancer in the future. Similarly, we ask about any sort of what we call exogenous hormone use, meaning hormones we're getting that are not from the body. So in premenopausal women, this is birth control and postmenopausal hormone replacement therapy. There have been a lot of studies looking at this, and we do see a bit of an increased risk in women who are on birth control, specifically the hormonal combination estrogen progesterone, same as women who are postmenopausal on combination hormone replacement. The good news is that once these medications are stopped, your risk actually starts to decrease and eventually goes away after about 10 years. Family history, also important. And Rachel will speak much more to this than me, but having multiple family members, first degree relatives with breast cancer, even if there's an absence of a genetic mutation, we do know that the increased risk is there.
Thank you. Dr. Jackson, what are dense breasts and how is it determined and communicated to our patients?
Thank you for this question, Dr. Oxenberg. So when we think about dense breasts, we look at it on a scale of how much fibroglandular tissue you have within your breast. Typically, this is diagnosed by a mammogram, and we have 4 different types of breast densities. The first one is almost entirely fatty, which means that essentially you have minimal fibroglandular breast tissue in your breast, and it's mainly fatty breast tissue. The second is scattered fibroglandular tissue, which is, as it sounds, that you have areas where there's scattered fibroglandular tissue, but mainly fatty breast tissue is within the breast. Now, there are only 20% of the entire population of women that have extremely dense and heterogeneously dense breasts. And that is seen on a mammogram, where you have a majority of the breast tissue that is composed of this white tissue when you're looking at it on a grayscale with x-rays, and that is densely packed fibroglandular tissue. Now, this is only communicated by mammogram because mammogram is essentially the only modality that we currently have that can initially be the first step to diagnosing somebody with dense breast tissue. And the way that you will see this is in your is in your mammogram report, where it'll say you have heterogeneously dense or extremely dense breast tissue, and that this may reduce the detection of smaller masses. And the reason it reduces the detection of smaller masses, which in essence means that there can be some tiny breast cancers hidden within your breast that we as radiologists may not be able to see, is just because of the density. So it's almost like if you were standing in a blizzard in completely whiteout conditions and somebody was 2 or 3 feet away from you, the further away that you get from this person, you can no longer see them. So that's how I incorporated into explaining this to a patient when I say that your breasts are extremely dense, for example, is as if I'm driving in a snowstorm and I cannot see the red light as it's approaching, meaning that something that I would see any other day is completely obscured. So that's why when we tell patients about their breast density, the next step is that depending on your risk factors, essentially what Mary was going into, early menopause, late menopause, early menstruation, family history, etc., we may recommend additional supplemental screening. And there has been a recent bill that was passed by Pennsylvania. It was the Bill 595, which covers additional supplemental screening for women that fall into the extremely dense breast category and the heterogeneously dense breast category. And with these particular subset of patients, which again is about 20%, we recommend that they either get a contrast enhanced breast MRI, which is more sensitive, not always specific, but very sensitive for detecting additional abnormal findings because it uses a different type of modality, which is separate from mammography. But if the patient doesn't have access to MRI, as we know, some rural facilities or certain places in the inner city may not have access to breast MRIs, we are also recommending that these patients can have complete whole breast ultrasounds, which is standard across any breast center, whether it's a center of excellence or just a standard breast center in any facility. And this is a second tool that we can use in addition to mammogram to detect smaller masses or anything that's suspicious in women with dense breasts. So to circle back to your question, breast density is detected by mammography and it is communicated in your mammogram.
Thank you. When patients do get additional imaging, I just want to add that we typically do it in intervals, correct? Can you comment on the intervals that we typically recommend if supplemental imaging is recommended?
Yes. So a patient, let's say, for example, you come for your first screening mammogram this month. So 6 months from this month, you would be getting a breast MRI if it's recommended, or a whole breast screening ultrasound. And then another 6 months, which would essentially be a year from, the mammogram that you got today, you would get a screening mammogram. So I say in the middle of every year that you get your mammogram, you're going to either have a breast MRI or a whole breast ultrasound, and they just rotate. So it seems like you're coming back often, but in essence, you're still getting a mammogram once a year. So I know patients are always complaining or they just feel that the compression is not comfortable, but it's once a year, and a 1-year compression can save your life from a highly aggressive and advanced breast cancer, which has a whole extra series of things that nobody would want to go through. And then you get that mammogram 6 months from that day, you're either going to be getting a breast MRI or a breast ultrasound.
And they both detect different things sometimes, correct?
Yeah. So the breast MRI, we use contrast. So if you have a contrast allergy to CT dye, does not contraindicate you from having a breast MRI, because that is a different type of dye. It's gadolinium based and it's a different mechanism. So that's one. So when we're looking at enhancement, because that's essentially what the breast MRI is looking at, it looks for suspicious enhancement that comes in very different patterns, which, I won't put out in this conversation because it's too technical, but it looks at enhancement. It can also see masses, which you can also see on ultrasound, but it may look at them differently, which may give you some suspicious features. And it looks at areas of distortion in the tissue, but it's not as sensitive for that. So the main thing that MRIs look at is enhancement. And then with ultrasound, it uses a sonographic wave where it just penetrates through the breast tissue, almost like sound from a, I don't know, like a whale or something. Like it bounces back to the dolphin, and then the dolphin bounces it to the other. So it goes through the breast, it hits something, and then it bounces back to the ultrasound detector. And this looks at masses. It can find cysts, which are essentially little balls with water in it, which are totally benign. It can find little clusters of cysts that look like grapes on mammography, and it can look like grapes on ultrasound, and that's also benign. And it can find dilated ducts. So that's like the spectrum of what we can see under ultrasound. But what ultrasound sees and what mammogram sees and what MRI sees can all be three different things. And what we do as radiologists is say what out of these modalities is the most suspicious, and that's what we would target for biopsy if we thought you had something that was abnormal in your breast.
Thank you for the clarification.
You're welcome.
Next question. Rachel, what factors can increase your risk for breast cancer, and how do genetics and family history play into determining who is actually high risk?
Thank you, Dr. Oxenberg. And as Mary had briefly pointed out a little bit earlier, family history of breast cancer is a known risk factor for developing breast cancer, and it's one that you cannot change. As a genetic counselor, I look at various aspects of the family history. The main thing is the degree of relation. So if you have a mother, a sister, or a daughter who was diagnosed with breast cancer, your risk for breast cancer will be about 2 times that average risk. And mothers, sisters, daughters, they are first-degree relatives. We also look at how many people have had breast cancer in the family. So if you've had 2 first-degree relatives with breast cancer, your risk for breast cancer could be up to 3 times the average risk. Relatives diagnosis is important because we want to determine, that percentage of how many people had breast cancer in the family, but we also look at age at diagnosis. So if there's a diagnosis of breast cancer under age 50, that's going to be a stronger risk for you compared to having a relative who was diagnosed with breast cancer at 60. So for example, if you have one maternal aunt who had breast cancer at age 65, that's not going to strongly impact your risk for breast cancer compared to if you had a sister who had breast cancer at age 45. That younger age at diagnosis can mean that there's a stronger hereditary link. And some hereditary markers can impact the risk for breast cancer significantly, and they have a large risk. Some other hereditary risk factors are more of a slight risk factor. The impact is not as large. So we can test for those large impact hereditary factors, and some of those more medium or small genetic risk factors we might not fully understand at this point in time. But if you're looking at your family history and you see 3 generations of breast cancer, so maybe it's tracking in a great grandmother, your grandmother, and your mother, that would qualify you for genetic testing. That's a signal that we could be dealing with a strong hereditary risk factor. Other cancers besides breast cancer can also clue us in that we could be dealing with the hereditary risk factor for breast cancer. So if you have a family history of ovarian cancer or pancreatic cancer, that does make us think that maybe there's some sort of hereditary link, maybe with the BRCA genes like BRCA1 or BRCA2, or other similar genes like PALB2. So those are some examples of high-risk genes that could be at play. And those patterns in the family history are something that we really pay attention to see if there is a high likelihood that there's some sort of hereditary risk factor tracking in the family. If somebody does test positive for one of those hereditary markers for breast cancer, we send them to the high-risk breast program so that they can get the adequate screening that they would need and surveillance. We would also recommend that their other relatives consider the genetic testing. And if someone tests negative for a high-risk genetic marker for breast cancer, they still may have high risk for breast cancer just based on the family history alone, or Mary, you had pointed out all of those other factors related to hormone history or the breast composition, like Dr. Jackson pointed out. So normal genetic testing doesn't remove the breast cancer risk, especially when we look at it in combination with a lot of other factors. And just to note one common misconception that I hear, if there is a paternal aunt who had breast cancer, that still matters, even though it's coming through your father's side of the family, or you're related through a male. So those kind of things we pay attention to in a family history, and it's something that when we're taking a comprehensive family tree, all of the diagnoses in the family are important, not just from one side of the family.
And thank you for reinforcing that. Even though we have a lot of patients that do have strong family histories, we don't. Not everybody does have a genetic mutation. It's obviously important to get screened, but those patients without the genetic mutation may actually still be pretty high risk, as you both have already, or everyone has already said. Mary, my next question is, what can a patient who is high risk and or has dense breasts expect during their annual screening? And then in addition, are there things that they can do to reduce their risk?
Yeah, so sometimes women come to me knowing they're high risk. So if they see Rachel, they have a gene mutation, or sometimes they have a diagnosis of what we call a high risk lesion. So there are 3 in particular that we know really increase risk. So atypical ductal and lobular hyperplasia and LCIS. So with these patients, I do have discussions specific either to the gene mutation or to the type of lesion that they had, because we do have national guidelines that help drive both screening and risk reduction for these really high risk women. If they come to me and they don't initially know they're high risk, I ask all those questions that I had mentioned before. We also talk about body mass index, alcohol use, those also come into play. And I actually enter their information into a risk application I have on my computer. What that does is it takes into account all of those factors and it runs it through multiple different risk models. And what these models give me are a lifetime risk estimate and then 5 and 10-year risk estimates as well. And this is kind of what drives my discussion with patients on, what does it mean for you specifically to be high risk and how do we change our management of that? So women who have a lifetime risk estimate of about 20% or greater, that's when we start talking about that supplemental breast imaging that Dr. Jackson kindly explained to us. So oftentimes MRI, sometimes ultrasound. The 5 and 10-year risk is what helps us decide if a woman qualifies for what's called chemoprevention. I'm not a big fan of that name. A lot of people think that means chemotherapy and it scares them, but it is not that. They're actually medications that help block hormones. There have been multiple studies looking at multiple drugs that show that they do help reduce the risk. Now, of course, the decision to start these medications is always a joint decision with myself and the patient. And there are a lot of factors that have to come into play here. So it's not just their risk estimates, it's also their age, if they're pre or postmenopausal, and any underlying comorbid conditions. So that's risk reduction for some really high risk women. But there's something that everybody can do. So lifestyle changes are really important. Being overweight, especially post-menopause, does increase the risk. So we ask women to try to maintain a healthy body weight. Physical activity also really helps with risk reduction. So we say about 2.5 to 5 hours a week of moderate intensity physical activity, or 1 to 2 hours a week of strenuous, actually really cuts back that risk. Similarly, if you want to have a drink, that's fine, but please limit it to 1 drink a day or less, or what that equivalent will be. Women who are high risk, I do keep an eye on them. So they see me in clinic at least once a year for a clinical breast exam, sometimes twice. And these visits, we go over imaging, any breast concerns they may have, but we also update their risk estimates. So is their risk going down? Is their breast density down? Is there a new family history? And again, just go over what they can do to help reduce the risk as well.
Thank you. Dr. Jackson, what questions should a patient with dense breasts and or patients determined to be at high risk ask their radiologist during their annual screening?
So really, it's the radiologist who should be asking the questions, and then that's us educating the patient so that they know the information so that they can share this with their provider. Because usually we see the patient, we see their mammogram, we're like, oh, this patient has dense breast. So I know before you. So, what we should be doing is telling the patient that, you have dense breast and this is what it means. And then asking them questions about their family history. We don't do an intense risk scale stratification as what Mary would do, but we do use a Gale score, which is automatically embedded into our system at Geisinger and Epic. So to tell us if they've had like a mother that had breast cancer, less than 50 years old, or anything that makes their risk factor. So really, we should be the ones going and asking the patients more questions to get more information, which then would prompt us to suggest that they have an official high-risk assessment in a high-risk breast clinic and then possibly an MRI. Now, if the patient is just curious, because if we're doing our part, then they will know. So then there's nothing they need to ask because they've been informed, they've been enlightened, and now they have the autonomy to know that this is the information that I have. And then they can share this with their provider, even though it'll already be in the report, but they could just ask like, okay, well, my last mammogram said that I have dense breasts. What does that mean? That would be the first question. So then at least we can explain to them and show them a picture of their mammogram so they can visually understand what it means for us. And then they can say, well, I have no family history of breast cancer, so am I at increased risk? And then we can say, you're at an average increased risk based on your age. And the older you become every 10 years, after you get over 50 years old, your risk is going to increase exponentially versus someone without dense breast who comes to get a mammogram at age 35, unless their mother had breast cancer. So then we can say, well, your percentage is going to be, you're going to be at 12%. So you're still less than 15, which would be intermediate risk. And you're still less than 20%, which we would say is high risk, but you have a risk similar to the general population. This is what you can do. You can get that supplemental screening that I just mentioned, which can happen with the 6-month interval following your mammogram. And you can also see somebody in a high-risk breast clinic so that they can really get down to the nitty-gritty with your family history so that they can get a better risk assessment with BRCA Pro or tyrosine. And then if you meet the criteria to get an MRI, then you should start getting MRIs. If you meet the criteria for chemoprevention, then you can start chemoprevention. But really, it starts with the radiologist having a conversation with those particular patients, which again is about 20%. So it's not like we're going to be pulling every patient that comes in our center to get a mammogram. It's just a small percentage and letting them know, like, this is what we see. You may be at risk. We would like for you to follow up with these patients, or vice versa. If they've already gotten a mammogram, which they started this at age 40, which is the standard of care age through the American College of Cancer and the Society of Breast Imaging, And the Surgical Society, everyone starts at age 40 and they get that mammogram that says you have dense breasts. I mean, the first question they could say is, what does that mean and how is it going to affect me going forward? And should I take any additional steps to make sure that cancers are not missed?
Sometimes patients, I feel, ask what some of the terminology means on their mammogram too. I don't want to spend a lot of time, but if you can just kind of briefly go over and not exactly biroids, but, when there's an indeterminate finding, when it's probably benign, because I feel like those are the questions we get a lot that patients get very nervous about.
Yeah, so there's been studies that were conducted, before I was even in medical school. So this dates back to the early 90s, maybe even the late 80s, where Dr. Sickles and some other physicians looked at these probably benign masses with, imaging wasn't the best then, but we were still detecting breast cancers. And they would see fibroadenomas, for example, which are benign tumors in your breast that are more common in younger women, and they typically calcify as you age, or they'll see these cysts, and they would follow them for years. And then they determine what is the time to growth period for a cancer. And it's been studied that most cancers, if it truly is cancer, is going to grow in 6 months if it's aggressive. And if it's not aggressive, we'd say, oh, it's going to grow within a year. And if it doesn't, they say at max, it can take 2 years to 3 years to grow. So when we see something and it doesn't fall into our world of this is a benign lesion that we can put in a bucket and say, you can forget about this, we're never going to look at this again. Actually, when we see you next year, we're going to even ignore it and act like we never saw it. That's called a probably benign lesion. So that could be a fibroadenoma. That could be a complicated cyst that may look like a solid mass, but it's just a cyst with debris. So like looking at a balloon that has sand in it, you can't see through it. So it's just kind of dirty. So we just say that we don't really know what it is, but we don't think it's cancer. And when I say I don't think it's cancer, there's a 98% chance that I'm accurate, that this is not cancer, but there's a 2% chance that I may miss cancer. So I like my odds of being 98% right, but I still kind of nervous. So we're just going to follow you for 2 years. So we follow you. Most of the follow-ups are for 2 years. And what we're looking for is a change. And it's either it's going to change in size, meaning it's going to grow, or we're looking for the borders to change, meaning that we can't draw a circle around it and trace the borders anymore. So now the borders look kind of weird. We don't know what it is still, so we'll put a needle in it at that time. Or if it starts to get vascular and just look totally different from a year ago. And that's when we have the right to take you out of a follow-up, which would be a BI-RADS 3, probably benign follow-up, and we'll do a biopsy. And we would do that based off of the best way we see it. So if we see it as calcifications that look like little grains of salt and they're getting bigger, we can biopsy by X-ray. And if we see it as a mass that's changing, then we'll biopsy by ultrasound. But if we follow you for 2 years and there's absolutely no change, then we say, okay, this is either a fibroadenoma, which we've already established is a benign entity, or a cyst, which we've already established is a benign entity based off years of research. And we just put you back in screen and we just ignore that forever, unless it does something different, 10, 20 years from now. But most of the time it doesn't. And that's why we're confident with saying that you can go back to screening.
Thank you.
You're welcome.
Rachel, so what is genetic testing and who actually is eligible for genetic testing? And is it covered by insurance?
So when we talk about genetics, we're talking about our traits. So we have traits for eye color. We have traits for height. These are traits that are linked to higher chances of developing cancers. Genetic testing will, we could refer to it as a spell checker. So it will look at the genes that have a known link to breast cancers and let you know if there's any kind of spelling changes within that gene. And the genetic testing is a blood draw, or we can actually do cheek swab kits now, which are very popular lately. But that can zoom in on your DNA and let you know if there is that hereditary risk factor. So the genetic report will say, in this specific gene, there's this specific misspelling, and we know that translates to a 3 times increase in risk for breast cancer. So the key thing about genetic risk is that it is not a guarantee that you would ever develop cancer. It is a known risk factor. And just like your family history, you can't change your genetics. You were born with them. But it is something that if we can identify that you have this genetic risk, we would want to get you into that high-risk screening program. And as far as the criteria for getting genetic testing, there's a specific set of family history criteria. Some of them I had briefly mentioned before, like if you have 3 relatives on the same side of the family with breast cancer, that qualifies you for genetic testing. If you have had breast cancer under age 45, or if you have a family member who has breast cancer under 45, or if the breast cancer is triple negative, where there's no hormone markers, that qualifies you for genetic testing. As I had mentioned before, things like a family history of ovarian cancer or pancreatic cancer, we know that in some genes that are linked to ovarian cancer or pancreatic cancer, they also confer a risk for breast cancer. So even if there's no breast cancer in the family, if there's ovarian cancer, we often get worried about breast cancer risk. So as far as the question about insurance coverage and cost, generally anybody who meets the family history criteria for genetic testing, most will have it covered by their insurance. Fortunately now, many of the large genetic testing labs will send you a out-of-pocket cost. So that way you can get an estimate of what it might cost out of pocket, of course, before you submit a sample or before the report is back. So that can help in some decision making. But the cost has certainly come down in the past 10 years or so.
I mean, when patients are typically referred to you, it seems that most of them meet the criteria for testing, correct? And insurance covers it, so the out-of-pocket cost is minimal.
Correct. Yep. A lot of people, you might hear they just have a lab copay. The labs that we use, if patients do have an out-of-pocket cost, it's typically at $100 or less.
Well, I think that's all of our questions for our panelists, and I really want to thank everybody for being so informative and answering all these questions. We certainly are trying to be more on the preventative side, in trying to reduce the risk of breast cancer and including increasing our cure rate when we can detect it early. So risk assessment is certainly a very, very important topic. So I want to thank all of our panelists who have done such fantastic work over the years on screening and educating and discussing what needs to be discussed with the patients. This ends the do you guys have any final thoughts? Anything else that you guys think would be important for any patient or any person to know?
Yeah, I'd just like to add a few points. For our young women who have family history of their mother having breast cancer less than 40 or less than 50, we do advise, at least for the less than 40-year-olds who mamas have breast cancer, we advise that they start getting breast MRIs at age 25 and they start having mammograms at age 30. We typically do not like to do mammograms starting at 25 just because the breasts are very sensitive to radiation. So that's why we say we can start MRIs for the first 5 years. And as soon as you hit 30, we start doing mammograms. And that should happen going forward, until. For our Black patients who are known to be diagnosed with later stage breast cancers and they're dying at a higher rate than our white patients, we do advise that they should start having risk assessments or at least the conversation about their family history at age 30, just because the cancers are being detected so late, even though they both are if you look at a Black and white patients together, they're at the same risk for breast cancer. So it's equal, but when it comes to survival, Black patients are dying earlier. So many organizations and societies have suggested that the conversations to start at 25, but no later than 30, about family history, or at least having a risk assessment. And if they are found to be at high risk, they should start having mammograms at age 30. And if they're truly high risk, greater than 20%, then they should also start having MRIs at age 25 and mammograms at age 30.
Thank you. Yeah, I think, so one of the common calculators, as you already said, was, available at cancer.gov. It's the Gale, there's the Gale model. And as Mary had already said, average breast cancer risk is about, 12 to 13%. So it's not a very small number. But when people see that number, that is average. But there are things that you can do, again, to reduce your risk. Lifestyle changes, but we really want to, people recognize that they can be high risk, and there's screening and even preventative options out there. Any other comments from any other panelists?
So something else that women can do is just know your breast tissue. You can have a clinical exam once a year, but your breasts are with you all the time. So you know what your normal is. Do you have new skin changes that aren't going away? Do you have a new nipple discharge? Is it especially from one side? Is it bloody? Is there a new lump that's getting bigger? So there are a lot of different things to look for. And actually, I do use Susan G. Komen. They have some really good resources as far as how to perform a self-breast exam, what things to look for, and kind of when to seek attention from a medical professional for those changes.
And lastly, I'd just like to say that the Society of Breast Imaging has a link on their webpage dedicated to patients and dedicated to providers. So if you ever have any questions about something that's written on your mammogram, or you're getting ready to have a mammogram or something else coming up in a future appointment, you can always go to that website, and they have links, they have videos that talk about getting biopsies, talk about getting mammograms, talks about cancer survival, the first time a woman was diagnosed with breast cancer, so that you can just find some relatable data and relatable information. And then they have links and people that you can reach out for if you have any questions. And then for any providers that are tuning into this conversation, they also have something geared just for providers with documents that you can give to a patient about a biopsy, or how to explain to a patient what to expect when getting a biopsy if they have additional questions after seeing their radiologist.
So obviously, there's a good number of resources out there. We encourage you to use the Susan G. Komen Hotline and Treatment Assistant Program. And honestly, the Susan G. Komen website has provided us a lot of information as providers, as well as a lot of patient education. So feel free to reference that. You can get more information on the Geisinger website, and obviously we see high and do risk assessment for high risk patients. So if there's any concern, we can see people in our clinics with just a simple referral. The nccn.org also has some very patient friendly pamphlets that can be discussed, even if somebody is high risk or has an inherited risk, gene mutation, and it breaks it down to make it simple. So there's plenty of resources out there. So I encourage people to really look into their own risk and encourage others to do that, so that we can do our best to prevent cancer going forward. So thank you to all of our panelists. This has been fantastic.